Thank you for joining us on our In the Know podcast series. My name is Nirmala Pereira and I'm your host today. I'm the social media coordinator for the IOC World Conference on Prevention of Injury and Illness in Sports. Also, I'm the member of Sport Without Injury program at Linköping University, Sweden, and currently I work as the Clinical Research Project Officer at the AIS. Today, we are very fortunate to have Dr. James Hull, a consultant respiratory physician at the Royal Brompton Hospital in London, and Professor Martin Schwellnus from Faculty of Health Sciences at the University of Pretoria from South Africa here. Welcome to the podcast, James and Martin.
Hi, thank you very much for the opportunity to join.
James, I know that you're involved in several projects, including symposium for the IOC conference that was postponed till next year. Can you tell us a little bit about what you have been up to?
Yeah, thanks, Nim, and thank you for the invite to contribute. We've been very interested in several projects looking at respiratory health in athletes, not just simply elite athletes, but a variety of different ranges from a variety of different ranges of sporting backgrounds. Most recently, I've been working very closely with the English Institute of Sport, and we've been interested in preparing athletes for what would have been this year's Olympic Games and looking at different factors which might contribute to poor respiratory health, particularly looking at factors which might underpin risk of increased infection. Generally speaking, my day-to-day job is looking after patients with asthma at the Royal Brompton Hospital, and my sporting work is done, as I said, with the English Institute of Sport, but also more recently with the Institute for Sport, Exercise and Health at UCL.
Can you also share what it was like to work as a respiratory physician during this pandemic?
Well, I mean, I think it's been very, very challenging time, obviously, for lots of people and in different settings across Europe. In our own specific setting here at the Brompton, we were reconfigured to provide critical care support for those at the very severe end of the spectrum of COVID-related infection. So patients who are intubated in requirement of intensive care support. I think broadly, the most challenging environments have actually been in the A&E or ER departments, and has been particularly challenging for nursing specialists in those settings who have been working incredibly long hours. And so we're fortunately starting to see a reduction in the numbers coming in through the front doors. And I just hope with social distancing, certainly in the UK, that reduction will now persist.
Certainly hope so, and it's been fantastic. All the healthcare workers working really hard to look after everybody. Martin, I know you're involved in many things, including being on the scientific committee, member on the IOC Advanced Team Physicians Clause, as well as the IOC conference. Can you tell us what's your involvement?
Well, I like running and cycling every day, so that is an important component of my life. But I currently am the director of the Sport, Exercise, Medicine and Lifestyle Institute, or SEMLI, at the University of Pretoria. So that's my main job, where I do clinical work, I do some teaching, and I have a large research component. But apart from that, I'm also the director of the IOC Research Centre in South Africa, one of the 11 centres that the IOC has around the world. And I've been doing that for about 10 years. And I guess more to the point here with respect to IOC activities, and particularly what we're discussing today, I've been approached last year by the IOC to lead an IOC consensus group. I'm sure many listeners and so on will know that there are these IOC consensus statements that are brought out every year. And so last year, we put together a group to look at generating an IOC consensus on acute respiratory illness in the athlete. And so we started working, and James is part of that group, a very important member of that group. We started working actually probably towards Q3, Q4 last year already. And so with the current pandemic, of course, this has thrown our activities into a completely different world, in the sense that precisely what we're all dealing with at the moment is in fact an acute respiratory illness, and it does affect athletes. And so one of the things that we've been involved with very recently is the bringing another subgroup under that group together of lots of experts around the world to actually bring in the effects of this particular COVID pandemic into the work of that consensus. So this consensus group will continue its work for the next 6 months or so, and we hope to have our consensus meeting and then the final consensus document a few weeks to maybe a month or two after the rescheduling of the IOC conference.
Yeah, that's pretty impressive, and I'm sure the audience will be very much interested in the outcomes of those. Perhaps we can catch up down the track again. Now I have some specific questions relating to COVID-19 and sport. So can you tell us, how does COVID-19 harm the lungs?
Yeah, so I think the first thing to say is there's still a lot we're learning about this virus, and data is emerging in papers almost on a daily basis. What we do know is that the primary insult to the lung, certainly in the moderate to severe end of the disease spectrum, is that there appears to be what might be best termed as a sort of over-exuberant or exaggerated immune response. So the virus gets in, starts to cause some irritation, but it's actually the immune response to that virus which causes the principal problems in the lung. And what we see is an inflammatory infiltrate in the lung air spaces. So if you look on a chest x-ray, for instance, you see patchy shadowing across the x-ray. If you look on a CT scan, it's a very sensitive marker, and virtually all patients who develop a cough or some degree of breathlessness have changes that are apparent on a CT scan. And of course, in some individuals, that develops into a much more dramatic form where you get considerable and diffuse airspace filling, and that looks like what is termed as ground glass change on a CT. The other interesting thing in this condition, which again we're learning a lot about, is the fact that it appears to cause problems in the blood vessels that supply the lung. Now that might be to do with embolism, so clots that end up in the lung, but also there appears to be some data suggesting that it can also promote thrombosis, so clotting within the blood vessels supplying the lung. And of course that has profound implications for oxygenation. So we see patients who come into hospital, they may be coughing and they're breathless, but their oxygen levels are considerably reduced. And as people will be aware, one of the big challenges in looking after patients with certainly moderate to severe disease is being able to maintain their oxygenation status. So there are a number of different components or compartments of the lung and the thorax which are being affected by this condition. And as I said, there's a lot still to learn about that.
We've also been hearing a lot about the biphasic nature of COVID-19 symptoms.
Well, we're certainly still learning a lot about how people might develop symptoms. And, one of the problems certainly in the UK is that access to good tests or diagnostic tests in the early stages of what might be a mild syndrome has been very limited. So we haven't necessarily had the gold standard comparator to enable us to say, look, whether actually people have got COVID. And so some patients have had what might appear to be a mild illness that's completely gone away. And in fact, people have gone around saying, I'm sure I've had COVID. And then there's been other people who have gone through what you term a biphasic phase, where essentially they develop some symptoms early on. So they might get a bit of a cough, some flu-like symptoms, a bit fatigued. And then that seems to start to settle after about 3 to 5 days. And then it's about somewhere between 7 and 10 days the symptoms seem to recur with more prominent cough, more prominent fevers and breathlessness. And in fact, if you look at the timings when people are typically admitted to hospital with severe manifestations of COVID-related disease, it appears to be around that time when most people are admitted. And of course, that has implications for return to play. I'm sure Martin will talk about this in a little while, but it potentially opens up this concern that this doesn't behave like a typical low-grade viral infection that people might get over 3 to 5 days and then can return to vigorous sport. There is this concern that there is this window whereby you don't really know whether people are going to fall into this period of vulnerability that seems to be about a week out from the initial onset of infection.
We know that a lot of people are coming out of lockdown and they're starting to become more and more active. How does this hibernation affect their ability to participate in sports and exercise?
What I find quite interesting is that the term lockdown is a very variable term around the world. So some people or some groups of people in different countries, even parts of a country, experience the so-called lockdown varies quite a lot. So that is an important factor when we look towards going back to sports or activities after a so-called lockdown. So I would say that it depends on what the person has been able to do from a physical activity sport point of view whilst they were in this lockdown. So it could be that people were completely confined to homes or small apartments, in which case the ability to exercise and continue the activity has been very limited on the one end of the spectrum, to other areas where in the world perhaps where lockdown was defined as changes with respect to going to shops and so forth, but where exercise was pretty much allowed freely, in which case people could continue very much with their training and not maybe organized sport, but certainly individual training. So in terms of how people would go back, I would say the first group, the ones where they have been confined to their homes, inability to go back, then the normal principles of getting back to sport and physical activity would be a gradual increase and a gradual progression with their training and their training load, and perhaps even with the type of training that they're doing, in order to prevent injuries would be one thing, but also to allow the body to adapt to a normal training load. And one can bring in perhaps the immune system there as well. We know that moderate intensity exercise is a very beneficial aspect of maintaining good immunity, but that sudden changes in load, certainly for recreational type athletes, a very high increase may predispose them to a higher risk of a suppressed immunity, and that obviously in the current environment is not a good thing. So those, I would say, are the main principles and things around lockdown and getting back to sport or activity that we have to consider. There are many other things, but those are the main principles, I think.
We know that a lot of the leagues are starting to or planning to come back, like football or rugby.
All right. Okay. So that would be the other aspect now. So if we're now looking at getting back organized sport, either ranging from the top elite level, professional level, down to children going back to school and organized school sports. So it's an entire spectrum. I think they're the principles here, which lots of organizations, including departments of sport in various countries, but also international federations and so on, are grappling with, is to balance the importance of getting back, which has got many, many benefits to it, against the possible risk of now an increased risk of transmission of the virus amongst the team members, and even between team members and officials, which include referees and coaches and so forth. And so that is a very hot topic, very hotly debated. And many organizations have actually brought out some really good basic guidelines to look at that. But essentially all these guidelines come down to taking what we do know, perhaps what we don't know as well, about how the virus transmits itself between individuals, and mitigating those risks. And they are sometimes very sport specific. So just to give you two examples, perhaps guidelines around how to get back to mass participation events like the London Marathon, for example, or other mass events is very different to perhaps the guidelines related to getting back professional football or golf. So there are very sport-specific aspects to consider here as well, where contact sports, for instance, would obviously pose a much higher risk, as opposed to sports where it's an individual performing on their own to a large extent, and where social distancing within the context of the sport and the competition can be maintained. So, that would be broad guidelines. There's also obviously the issue of travel. There's the issue of sharing facilities, both in terms of locker rooms, and then another area would perhaps be obviously the sharing the facility with which the sport is conducted, like a football or a rugby ball, contact. So these are all considerations, and we're all grappling with the same issues. The big thing is we have often very little information to base our guidelines on.
Hot topic here about spitting and using sweat, for example, in cricket or football.
We now delve into some very specifics about how possibly transmission could take place. and it would be related to the fact that there would be a shedding of the virus onto various surfaces and equipment and individuals that you are in close contact with. For example, let's say somebody with a asymptomatic infection who's a rugby player and they are in a scrum and is coughing, then 16 other players are potentially exposed. Or there are nasal secretions, or there's saliva, there's any fluid containing the virus that is mixed and then possibly gets contaminated. So I think all these issues are, a potential risks for transmission, and that's where the mitigating policies and procedures and guidelines come in. But maybe, James, you want to comment specifically maybe on the methods by which the virus can transmit through, let's call it body fluids, particularly those emanating from the upper respiratory tract.
Yeah, I mean, I'd echo what you say there, really, Martin. And of course, the primary method for making a diagnosis at the moment is nasopharyngeal swabs, which generally speaking are taken as a deep swab, but certainly in the states of an acute viral or the onset of the symptoms, there are high viral loads in the buccal and nasopharyngeal mucosa. So, it is very conceivable that secretions emerging from that part of the airway tract are going to be infectious. The other thing to say is that some elite bodies might say, well, if we've screened our athletes with a single nasopharyngeal swab and those tests have come back negative, then actually we can be a bit more relaxed about this, and the risk of transmission is actually very low. Certainly from data in the UK, we know that actually as many as one in 4 of these swabs can actually come back as falsely negative. So clearly that's why there are policies emerging that put teams into isolation prior to returning to sport, but also might take multiple swabs in order to try and reduce the risk of having a false negative report. So I think overall a recommendation has to be, look, actually allowing people to expel secretions in close proximity to others is really not a very sensible, logical or safe thing to be doing at the moment, and all recommendations should be to try and reduce and minimize that, within the abilities of a certain given sport.
James, you mentioned before, majority of people either had mild or no symptoms. So there might be people that had COVID-19 and they don't know that they had it. And if they are coming back to sport, are there any red flags that they should look out for?
See, this is a difficult one because there are lots of people who felt that they've actually had the condition. And actually, interestingly, this week, certainly in the UK again, we're starting to see the first data emerging from more broad and widespread testing with antibody testing, i.e. the ability to say whether people have actually mounted an immune response, which suggests that they were previously infected. And I think it's been disappointing for some people. Certainly there's been some famous radio news reporters in the UK have talked about this within the last week, who were utterly convinced that they'd had COVID, they had anosmia, they had a dry cough, they had a fever, and their antibody tests have come back only this week as completely negative. And of course, we know that for those who've developed simply mild symptoms, there is a lot of overlap with the general type of infective pathogens that we see, particularly around the winter and early spring months. So we'll only start to see from larger data series, what has been the relatively mild or asymptomatic carriage rate as the antibody studies start to provide us with some more detail. When you're talking about sport or sport considerations, because we don't have widespread access to the testing at the moment, I think the only way to proceed safely is to assume that someone who's had COVID-like symptoms, particularly a cough, fever, and very prominent ENT symptoms, is to assume that they might have had COVID, and then to apply a COVID RTP strategy for the reasons that I've said before. And the red flags really are, I suppose, threefold. One is that we need to think and be aware that this condition in some people, particularly those at the more moderate to severe end of the spectrum, so for instance, if someone was at home and they were bedbound for a number of days, they may have developed long-term sequelae, and so they might have had, for instance, an X-ray change which wasn't identified, and so they might need an X-ray to determine that they haven't got any ongoing changes. they might develop palpitations or chest pain, and that might be a manifestation or a warning sign that there may be a potential for cardiac irritation. And again, certainly in the moderate to severe end of the spectrum, there is a definite recognized prevalence of irritation of the heart muscle, and certainly case reports and series now of myocarditis developing. And then the third, and I think the most important red flag, is that we're certainly seeing that people who've had what is considered to be mild or moderate disease, who are very breathless, who have been found then to have thromboembolic events. And so they had pulmonary emboli that identified on a CT scan. And so if you see an individual who you think this breathlessness does not add up, or they're struggling to do what I would really have expected them to, really be done pretty easily after a viral infection, then you must think certainly about cardiac problems, and you must think about whether they could have had silent or hidden thromboembolic events.
Now let's talk about somebody that had COVID-19 and recovered from it. So if somebody is returning to sport after COVID-19 infection, what kind of precautions do they need to have to safely return back to sport?
Let me just open up with this, in terms of, we go back to the return to sport guidelines after COVID infection. I think one of the points that James was making is that there are a lot of people out there, a lot of athletes out there who had a respiratory illness, which may have been on the very mild side, even perhaps asymptomatic, and on the moderate side. And of course, the ones that are on the severe end of the spectrum, with hospitalization and so forth, it would be a confirmed, COVID infection. But on the other, let's just make it clear that those are maybe 5 to 10 or even less percent, particularly in a younger population, even less. So we're talking about an approach here to 95% of young active athletes who have had a recent acute respiratory illness. And James, you were talking about the fact that in the majority of these people, you may suspect COVID on the basis of the kind of symptoms that they had. But even the radio personality you were talking about, who thought they had COVID and didn't have COVID, that's precisely what probably a lot of young people and athletes experience. So in a way, the return to sport after COVID should actually just be return to sport after an acute respiratory illness, which may or may not have been confirmed COVID. So my personal opinion about that is that the best advice is to go back to some extent what James said, is to try and ascertain whether we're talking about a mild illness, a more moderate or severe illness. And in my advice to people, I divide the guidance on that decision based on three things. It's the type of symptoms. James mentioned that there's certain that perhaps are more likely to be COVID. The duration and severity of those symptoms, how long they last and how severe were they at the time. And then the last point is whether or not this diagnosis was confirmed with a known pathogen, yes or no. Because if it is a known pathogen like COVID, then we would have a certain suspicion and we would check things certainly. A lot of the time, and I think there are some studies out there, there are, concomitant infections. People would have a positive PCR on more than one organism, COVID plus something else. So the return for me would be for the clinician or for the athlete or coach is to make kind of this decision. Am I dealing with a more mild illness or a moderate or a severe illness? And base, again, those on types of symptoms, duration of symptoms, severity of symptoms, and either known pathogen or not. And, the mild ones, which are the majority of the time, I think, the approach would be that you can probably go back to sport, but, mild being defined as a small number of days of symptoms, maybe 2-3 days or less, mild symptoms, no severe symptoms, only localized symptoms. Or perhaps if there was a pathogen like rhinovirus, then we know that that's also associated with a mild disease anyway. Those athletes, I think, would require less screening, less testing and so forth. And based on resolution of symptoms, they can probably go back to exercise. And I would then just also caution people to start off with a low intensity, low duration of exercise and see how they feel and respond to that. The moderate to severe is a completely different group, and I think those need what James was talking about, the comprehensive medical evaluation. And if there was a known pathogen like COVID, then precisely those things that, James, you were talking about in terms of lungs, is important. And then, our cardiological colleagues have also focused on the cardiological side, but I think we mustn't forget the other, multi-organ involvement of COVID, which also involves the neurological system, probably the muscle, skeletal muscle directly. People end up with muscle and myalgia and muscle pain and muscle soreness, muscle cramps afterwards, as well as, hidden organ systems that also may effect of exercise and safety, which is in the renal system and so forth. So I think we need to understand that if you know this is a moderate to severe illness with a known pathogen like COVID, then all of those other considerations become important.
My thoughts align with that. I would say, if I just add a little bit on lung function assessment, for instance, that people are interested in, and lots of people are asking me, could there be value in, for instance, checking spirometry? What I would say with respect to COVID infection is that there isn't a lot of data available. The data that is available and actually emerges from China and looks at lung function in patients who were discharged, that had lung function testing at the time of hospital discharge. So we're talking about patients who'd been at least moderately affected. They were hospitalized, and in many cases were actually in requirement of critical care support. By the time of discharge, the majority had near normal spirometric values, and the real defect was only identified with a measurement called gas transfer, which is a more complex lung function measurement. So I certainly don't see the key merit in assessing vast swathes of athletes with spirometric measurements, especially those who've had mild disease, other than to say that it might identify athletes who've had previously undiagnosed asthma, which we know is actually a substantial proportion. But certainly if you were looking at that as a measure of safety for return, I don't think there's going to be a lot of value in that. In contrast, if you had a breathless athlete who certainly had moderate to severe disease, then you would need to undertake more formal lung function testing, including measurements of gas transfer, plus or minus tests such as a CT scan and tests that look at the integrity of the pulmonary blood vessels.
James, may I just ask you about that? Trying to be practical. What about a submaximal exercise test during which at the very least, you would document things like the rating of perceived exertion and the rating of perceived breathlessness? That would be just a field test that a coach could conduct, and alerting them to the fact that if there's an abnormal response, and the athlete would probably know that needs to be flagged. The next step would obviously to do that in a laboratory setting and get a little bit more data, for instance, the heart rate response, which could be exaggerated from a previous test, or just simply what we would know a heart rate response would reasonably be for a certain age and type of athlete. In other words, do a functional test like an exercise test and see if everything is normal around the exercise test, and flag out of that who should then be referred for these special tests, which probably in the majority of cases, those 95% of people may not, have access to go in as a first line test.
Yeah, I think there's a lot of merit in that. There are some challenges, of course, as well. One is that unless you're in an elite system or you're in a monitored system, you may not necessarily know what the pre-morbid results were like. So you don't necessarily have a baseline for which to compare with. Having said that, certainly if you could develop a simple test, then the other added value from that would be able to track it more longitudinally. So for instance, you could do it on a weekly basis. And one thing that I've been keen to sort of highlight and point out is that if you're recovering from this infection, you should be recovering from it. So you would expect to be progressively improving on any physiological measure, and certainly you shouldn't be deteriorating. So if you saw a steeper heart rate response or a longer heart rate recovery, or you saw, for instance, the performance indices deteriorating allied with symptoms of worsening breathlessness, then sure, you'd have a marker which would support the supposition that actually things aren't improving, or they're not improving the right way, and that might be a gatekeeping function to the more detailed tests that would then be needed. I think the other thing that people have asked a lot about is whether oxygen saturation monitoring might add value. And as I alluded to earlier, one of the things that is affected is the pulmonary vasculature, and certainly this condition appears to play havoc with VQ inequality in the lung, and the way that the blood vessels align with the air spaces in order to pick up oxygen. So you wouldn't expect an athlete to rapidly desaturate when they're exerting in a submaximal setting. So if there's oxygenation problems, and again, that might alert you if you could have a finger probe SATs monitor during that test. It might provide a bit of additional information. You've got to be careful to make sure the quality of the SATs trace is good, and some of the devices you buy off Amazon for £25, you don't get a trace, and so you might be falsely tricked into seeing drops in saturation. But if you can have a decent monitor and you could look at that, there may be some value in that, and I think that needs to be studied for sure.
We know that endurance athletes have a high prevalence of respiratory illness like asthma or allergies. What is the best strategy to manage pre-existing respiratory pathology?
The advice from my side would be that you need to have optimized treatment and maintain that treatment during this period. But maybe, James, you want to be more specific about that?
Yeah, sure. You're quite right, Nim. I mean, the data now is pretty firm that at least 1 in 4 endurance athletes has some chronic or relevant respiratory issue, and most well known, of course, is exercise-induced asthma or exercise-induced bronchoconstriction. Probably less well recognised is a high prevalence of sinonasal disease, and particularly allergic rhinitis. But also, there's a very high prevalence, perhaps as high as 5 to 10% of young adolescent athletes get a problem where the larynx closes in a condition called exercise-induced laryngeal obstruction. So on that background, I think there's 3 things that are relevant to this current discussion. And one is that you need to make sure that if you've got an athlete who's got chronic respiratory problems, or in the background is a signal of chronic or recurrent respiratory illness, you need to try and establish whether there is a diagnosis of a condition, and you need to do that with objective tests. So we've known now from many studies that simply depending on symptom-based diagnosis is pretty poor and inaccurate in athletic populations, and so you need good objective testing to confirm a diagnosis. If there is a confirmed diagnosis, say for instance of asthma, then the next thing to say is there's been some really pretty fundamental and massive changes in the way that asthma should be treated as dictated by GINA within the last year. So many athletes will remain on simply a blue or a short-acting reliever inhaler, and actually the GINA guidelines completely changed the overall diagnostic strategy for asthma, in that they didn't feel this was an appropriate way to treat mild asthma, and actually use of an inhaled corticosteroid was pretty much mandatory now across the board in asthma treatment. So it's important that you review the treatment and you make sure that athletes are on logical treatment and in line with GINA guidance. And then the final thing is to say, look, actually, it isn't sufficient just to simply write a prescription for medication for an athlete. You've got to review how they're taking the inhaler, whether they're taking it in the right way, whether they're using spacing device, whether you're treating the nasal conditions that may contribute to poor overall respiratory health.
I just want to throw this out to both of you. In the part of my experience, what I worked about professional sport and exercise, particularly professional sport in a COVID-19 environment.
I mean, I'll just make I'm sure Martin will have thoughts on professional sport, but I would say that there is some encouraging data coming out, certainly in Science this week, showing that certainly in animal models of infection, that there does seem to be at least short-term immune protection from those that have been infected when they're reinfected. So in some ways that is encouraging. Now, how long that lasts, we don't know. And, some of the data from previous coronavirus infections suggests it may only be moderate term, which will have to be factored into certainly activities next year. As you allude to, the data we're waiting for is to see what the vaccine trials show and to see whether they're going to be an effective strategy, because that will be a game changer in terms of the way professional sport moves forward.
Yeah, I think I don't have much to add to that, except that I think we are all really waiting for the data that comes out of these types of studies, because we want to know that if somebody's had an infection, has had an immune response, we can measure the antibodies, that those are then protective. And then the questions for how long that lasts. I think these questions are just out, to be investigated. And as James indicates, I think initial very early data suggests that this is that at least we have a positive, some positive news around that, but we'll have to see. And depending on the outcome of that, it will affect, what we discussed in detail a little bit earlier about the risk of transmission and the degree of protection of an individual from either previous infection or from a vaccine.
Just one last question. How can we optimize respiratory health?
There's lots that can be done, and of course, it's the aim of the IOC consensus group led by Martin, obviously to communicate that and for us to provide really quite clear guidance, hopefully for the first time, to try and optimize overall respiratory health. I mean, from my point of view, there's probably three things which I think are, if you like, low-hanging fruit, or things that we ought to all be better at. First of all, we need to be better at removing irritants from the environment that athletes might face. And so, what is it about letting athletes exercise in polluted environments or in conditions which are inhospitable or toxic to the lung? What is it about letting people swim in very highly chlorinated environments, or race bikes in very heavily polluted situations? That clearly is not going to be good for the lungs, and we need to do more to try and remove irritants. The second thing is that, as I alluded to before, getting diagnosis right is very important, because it sets up the whole of the trajectory for how you might treat athletes, any respiratory symptoms they get. And so, week in, week out, I see, a vast number of athletes who've been misdiagnosed with asthma, or have had the diagnosis of laryngeal obstruction missed, and they've not got the right treatment, and they've not got the right treatment at a crucial part in their athletic development, and that might have huge trajectory or impact for their subsequent careers. And then the final thing is, we assume that if someone gets symptoms, they must be infective. So if you have nasal congestion or you start to cough, instantly it's assumed in the sports medicine world that must be a respiratory tract infection, and antibiotics are often used, or a way that people think is being logical to proceed. And we've got to get better, and we've got to get better access to the modern means of diagnosing bacterial infection, or thinking about the other issues such as allergy or inflammatory driven symptoms, so that we can target the best treatments in the right way to the right athlete.
So I think we will wrap it up there. I will also share the link to the Lancet papers written by both Martin and James on respiratory health in athletes, so open access paper. Also, if you have any questions for James and Martin, feel free to post them here. So thank you both. I really appreciate your time. Also, a huge thank you to our audience for joining us today.